Good evening, everyone. I'm Dr. Simone Rofena. I'm the medical director here at the Zita West Clinic. And tonight I would like to explain how we do IVF here at our clinic. So I will present you with some slides in which I explain the various aspects of how IVF is managed. But more importantly, I would like to give you the time at the end to ask some questions, because I believe that's probably the most useful part of this. So, and I'm sure you will have many questions to ask. So I will try to keep the presentation short to give you the possibility to ask as many questions as you might have. So about that, you can see two sections. One is to ask questions in a more private mode, and the other one is public through the chat. So feel free to use one of them accordingly. So starting with the presentation, I just would like to show you, I mean, although virtually, it would have been nicer to have this presentation in person, so you could have the possibility to see our clinic, but you know, it's not possible. So we can I can show you some pictures of our clinic. If we can go ahead. So this is myself and Dr. George. You can see Dr. George is the founder and previous medical director. I've now taken over the medical director position, but Dr. George will still be with us until July. So you can see some pictures of our clinic. We try to make a patient's experience comfortable from the very beginning. So we believe also having a nice and relaxing and calm environment is important, because the process starts from the very moment a couple get through the door. Is not just about the medical treatment, it's about feeling comfortable and feeling in the right place in the end. So these are just some of the testimonials of some of our patients. I mean, clearly we can't put them all, but I can assure you that we receive daily messages from a grateful couple whom we have helped having a family. So these are the key points to summarize, you know, the different levels which we believe are important when assisting a couple in the IVF journey. So we believe we have a unique approach to IVF. One of the things that our patients say making the difference is actually having a lot of time with the professionals, with the doctor, with the nurses. Our patients have access to doctors and nurses whenever they feel the need to speak with them. And this is something that is not available at all clinics. Some clinics do not give this possibility, but we believe that this is very important, because a couple should feel supported by the medical staff at any moment, and we do that. The other point which we are unique at is nutrition. Since we established this clinic more than 10 years ago, nutrition has always been a key point for us. So we include to every couple having IVF a free of charge nutritional consultation, at which one of our professional nutritionists will address the nutritional habits of the couple and try to give advice on how to optimize nutrition, because this is reflected, and we have seen this for many, many patients. This is reflected in the egg and sperm quality. A good nutrition and a good supplements lead to better eggs and better sperm, which is then reflected in better embryos. And finally, the holistic approach, so to support patients, not only in regards to, the medical part, but what we have seen during many years of supporting couple is that having an optimal body-mind relationships again reflects in having better results. So we support our patient through several services like acupuncture, counseling, hypnotherapy, just to mention some of them, which are aimed at putting the couple at ease and dealing with those difficulties which can normally be present when starting the journey at any point of the journey. It could be at the beginning, it could be after receiving bad news, after failure. There are several points at which a couple might need support, and giving this support is very, very important to overcome the difficulties that the process might entail, and ultimately to have a better experience and better results. So just to talk about the process briefly, the process consists in basically 3 phases. There is an initial phase called ovarian stimulation, in which the patient receives some medications. That phase normally entails 10 to 12 days, after which the eggs are ready to be collected. So after 10 to 12 days, we proceed with the egg extraction, and then the male is asked to give a sperm sample, and the eggs and sperm are put together. That is the fertilization and embryo development, which requires 5 days to be completed. After this additional 5 days, we are happy to select the embryos which are more suitable to make a baby. So once we select these embryos, we then put them back in the uterus. That is called embryo transfer. And then we wait 10 days to see whether the embryos we have introduced in the uterus have implanted. Go ahead. Yeah, so IVF doesn't work all the times, as probably many of you know. Actually, in fact, it works in less than 50% of the cases in most of the patients. But that is because, the nature follows its course. And the reason why IVF is relatively unsuccessful is because, unfortunately, most of the embryos we are able to create, even with IVF, do not have the genetic potential to make a healthy baby. So as you can see in my next slide, it, when an IVF cycle fails, this is believed to happen in at least 80 to 85% of the cases, because the embryo, which is this is a picture of an embryo, has a genetic problem inside. So despite looking, it can look good quality just at first sight, but it might still have a genetic problem which doesn't enable the embryo to successfully implant. And you can see on this right picture how much the likelihood of an embryo implanting decreases as long as the maternal age increases, up to the point that after the age of 40, you can see that the implantation rate reduces dramatically. And that is because the age is the main factor determining the possibility and the likelihood for an embryo to have a genetic problem. As long as a woman gets older, the vast majority of the embryos that a woman will produce will unfortunately have a genetic problem. We know that from the data available. And there is the possibility to assess before transferring an embryo into the uterus whether the embryo has a chromosomal defect. That can be done through a test called genetic testing, or PGTA, which is something that has to be discussed with patients during the initial consultation. Go ahead. Yeah, but the embryo is not the only player. Actually, the other player is the uterus, because we can put the best embryo in the world, but if the uterus has some problem, that embryo is likely to fail, because the uterus actually is not just a recipient. The uterus has an active role in regards to deciding whether to accept that embryo or not, and is able most of the times to understand whether the embryo has a genetic problem or not. And if the uterus identifies that the embryo has a genetic problem, it's very likely that the embryo will not implant in the first place. In some cases, the embryo can still implant, but the pregnancy will stop at some point, normally within 12 weeks. And that's when the patient, unfortunately, experiences a miscarriage. But the uterus can have some conditions in itself which might reduce the likelihood of a good embryo to implant. And these conditions can be infections, polyps, fibroids, which can be detected before actually putting an embryo back, normally at the diagnostic phase, so with a simple scan. And there are some other conditions which are not detectable with the scan, but are detectable with some specific test called ERA, EMMA, and ALICE, which I can briefly describe in a moment. There are some other factors that can affect the ability of an embryo to implant. For example, some patients are carriers of a problem called thrombophilia, which is an increased risk for the blood to form clots. And if that is the case, patients can experience repeated miscarriages. This condition is mostly genetically determined and can be identified with some tests, and the treatment entails basically blood thinners. Another condition that can negatively affect the capacity of embryos to successfully implant or to successfully, for the pregnancies to successfully progress, is called autoimmunity. And that's when the maternal immune system can actually trigger an immune response against the pregnancy. It's like considering the pregnancy as a foreign body, as something to fight. And in some cases, we believe that this could be one of the reasons why the patient fails or has a miscarriage. These conditions are detectable with what we call level 1 for thrombophilia and level 2 test. And we recommend this test in those cases which we believe might have these risk factors. And then there are other things which are very easy to be checked, like thyroid function and vitamin D, which are very, very important for the egg and sperm quality, particularly the vitamin D. So we test vitamin D for both men and women routinely at our clinic. And if it results that is lower than it should be, one of our nutritionists addresses that and recommends the right supplementation of vitamin D in order for the couple to have better chances to actually improve the quality of their eggs and sperm. And the thyroid function is also important, basically for the woman. And there are studies now showing a correlation between thyroid levels and likelihood for a patient not only to conceive, but to successfully carry a pregnancy. So coming back to the uterus, the other test I mentioned before, which are able to help the clinician to understand whether the uterus might have a problem which is not detectable with just a simple scan. So the ERA test was developed by a Spanish group in Valencia several years ago now. And they developed this test, which is helpful to understand whether the timing at which we are putting an embryo back in the uterus is actually the correct timing for that patient. Because we don't have to assume that all the patients are the same. In fact, this is not, and who treats patients every day knows this very well. Patients couldn't be any more different from each other. That's why it's very important that we personalize the treatment to every single patient, which we do at our clinic, and that is a key to help patients achieving a successful pregnancy, because there is no one protocol fitting all patients. And also, patients are different in regards to when they are ready to accept an embryo. So if a patient is not ready after 5 days to receive an embryo and we put an embryo exactly after 5 days, then the embryo might not implant, not because the embryo is not good, but because the window of implantation is not the right one. And according to this Spanish group, up to 30% of patients actually might have a different window of implantation, which means that we should put an embryo either sooner or later than 5 days. Now, this is still controversial after the first study from this group. Other studies have come out, some of them not confirming this, or at least not confirming this at such a large scale, because I mean 30% is quite a lot. So there is still a controversy in regards to whether the percentage is actually that large. But certainly, in my experience, I have treated some patients with a different window of implantation, and once we have corrected the window of implantation according to what the test was suggesting, so doing the transfer, the embryo transfer sooner or later according to the recommendation of the test, then we have treated some of these cases successfully. So in my opinion, this is a valid test, but what is not entirely clear is the extension of the problem. So how many patients actually would eventually have this issue. And alongside the ERA, the same group has developed two other tests. One is called EMMA, which is able to detect what is believed to be also important for a successful implantation. So the presence of the right amount of good bacteria, because we need some good bacteria for our organs to function. Is the same concept of what happens in the bowel, where you need some lactobacillus, a good amount of lactobacillus for our bowel function to be optimal. Well, the same thing is believed to be important at the uterine level, or at least is growing more and more importance and more evidence. And there is a test which is actually able to detect the amount of good bacteria in the uterus, and in case it is detected that this amount of bacteria, of good bacteria, is suboptimal, this can be easily corrected by taking some supplements, basically. And finally, there is a test which is able to detect the presence of an infection or an inflammation. And actually, all the three tests, the ERA, the EMMA, and ALICE, can be done within a single uterine biopsy. So the doctor needs to take a sample from inside the uterus, which is a procedure that can be done at the clinic, and it doesn't require anesthetics. It's a bit uncomfortable, but normally we give a painkiller half an hour before the procedure and an antibiotic, and the patient can have this at the clinic and go home straight after the procedure. And the results are normally available within 10 days, and we can then know whether the patient might have any of these condition, and put in place the recommended treatment for that. So I've just told you what is known, but undoubtedly there is quite a consistent proportion of things we don't know, and we have to admit that, because not everything is explainable, particularly in IVF, which is a relative recent field of medicine. I mean, the first IVF baby is I think is 45, 46 years old. So IVF is not a procedure that has been there for a long time when compare it to other fields of medicine. So there is still a lot we don't know, and hopefully the research, which is continuous in IVF as it is in other fields, will bring some answers to some unanswered questions. So there is still a good 15 to 20% of cases in which we are not able, and that's very frustrating, we are not able to provide an answer to the couple in regards to why the treatment has failed. On that, I think now the research is evolving to try to help with some of these unanswered questions. There is an attempt to try to bring back the clock and to extend the reproductive age, which is actually already a reality. There is the possibility to freeze some ovarian tissue when a patient is still in a reproductive age, and then once the woman has ended her reproductive age, there is the possibility to transplant this ovarian tissue back in the ovary, and the ovarian function can then restart to some extent. There are already clinics who have done this. And also that there is a continuous research into what could be those aspects of an embryo that affects the capacity of this embryo to make a baby, actually, as long as you try to find less invasive methods to test an embryo genetically, because the one we have available, the PGTA, is still invasive, so that entails removing some cells directly from an embryo, and unfortunately we know that in some cases this procedure can result in an embryo being damaged, which then eventually can translate into this embryo not being able to implant. So we are still far from being perfect, and that's why the research is continuously trying to find a better way and less invasive way to identify those embryos which are more likely to make a baby. As I said at the beginning, it's not all about medications. Actually, a very important part, which I think is equally important to the medications, is to support the couple emotionally. And in that respect, I think we are quite unique, simply because we were the first clinic in the UK to adopt such an attitude, which still persists. So we are proud to still, dedicate time to our patients, to support them. So all the members of our team are committed to that, from doctors, nurses, admin, everyone, because it's important to work as a team. And alongside that, we offer those services of counseling, hypnotherapy, nutrition, in order to be able to address all those areas which we believe are important to increase the chances for a couple to have a successful treatment. So yeah, I would like now to give time. I think we have good time for questions. I've tried to keep the presentation as short as possible while still delivering hopefully important information. But I would like now to give you some time to ask some questions. I can already see some of them in the section, so maybe I can start addressing them. I can see, for example, patients asking if they can exercise during treatment. Well, my general answer to that is yes, but once we enter into the thick of the stimulation phase, which is normally after 1 week of injections, it's better to privilege just a gentle form of exercise, like swimming or yoga, Pilates, not the things that entail jumping, because the ovaries, after 7-8 days of stimulation, start growing in size, and if a patient does some high impact activity, there is a potential risk for the ovary to move abruptly, and that can cause a torsion of the ovary, which is very painful. So the advice, the answer is yes, physical activity is allowed, but a gentle activity is better, particularly after 7-8 days of stimulation. Then I have a patient who is asking if the clinic is not open during weekends, how would the protocol work? Well, in fact, we are a 7 days a week clinic, in the sense that we still guarantee procedures 7 days a week. What we don't do is scans and consultations over the weekend, but they are not necessary over the weekend. We still do the egg extractions 6 days a week, and the embryo transfer 7 days a week, which is absolutely more than enough to cover any need, any clinical need the couple might have. So actually, practically, we are a 7 days working clinic, so there is no problem in regards to that. Then I have a patient asking what can be expected from a consultation, which I believe is another key point. So I thank this patient for the question, because it allows me to explain what is the difference between our clinic and other clinics. So we take the first consultation very, very seriously here. Patients are given 1 hour and a half for the first consultation. So it's a very, very thorough consultation, at which the whole history of the couple is taken into consideration. So if the couple has had other treatment elsewhere, we go through all the treatments and the outcome the couple has achieved, because that's very important for the consultant to understand where the problem might lie and to try to change things in order to improve the outcome. So, and also for those couple who are at their first attempt, equally, there is a very, very thorough examination of all the tests that they have been doing so far and their medical history to try to understand, again, what could be the most likely reason for their inability to conceive. And after this initial examination, then the consultant is able to make a plan, so to advise the couple on what, well, first of all, if they need further tests, and if they need further tests, then there is a follow-up at which the results of this test are seen, and at the end of that, a treatment plan is made. Wherever, if we have already all the tests necessary to make a plan after the first consultation, at the end of the consultation, the patient is told very clearly about what the best plan for them is, what the consultant thinks is the most successful. So the patient finishes the consultation with a clear plan on what to do next. Going ahead with the questions, so I can see, how do you detect if a patient needs this extra test like Emma and Alice? Do you do this on all patients, or if they have a lower probability of getting pregnant, say over 40s? Well, that's a very good question. No, they are not normally tests which are done immediately, because normally these are tests we ask after at least one failure, because the vast majority of patients do not have any of these conditions. So in my experience, at least 80% of the patients do not have any of these conditions. And these tests are quite expensive. So we need to understand when is appropriate to do them. So we normally ask for this test after one or more failures with good embryos, when we believe the problem might be the uterus rather than the embryo. So, I mean, the age is less relevant. It's not an age thing, because a patient can have a problem even at a younger age. Normally, the criteria are previous failed cycles with good embryo, when we think that the problem might be the uterus rather than the embryo. So moving on the next question, should I unfreeze my embryos, which are apparently good quality, and use PGTA, or should I put them back in me and risk another miscarriage? Well, that's a very good question. That's a very, very relevant topic. I've got patients asking me these questions on a daily basis, it is always good to look into every case. We can't generalize and say, oh yes, every patient should have their frozen embryo tested genetically. No, again, is when we think that that is important and more practical for the couple to know whether to test this embryo. So just to make a practical example, if a couple has 10 embryos frozen, and we start using one and it doesn't work, two and it doesn't work, then instead of waiting for 8 transfers, so to use up all the embryos, which will take a long time and cost quite a lot of money, it might be more helpful to decide after 2 or 3 failed frozen embryo transfer to just test the remaining embryos, which will tell us straight away if and how many of the remaining embryos have a chance to make a baby, actually, and that will save quite a lot of time and disappointment to that couple, because if we keep on putting embryos which do not have the potential to work, that's a waste of time and money and disappointment for the couple. So we need to understand the pros and cons, because the cons are that the genetic testing is expensive, so this has to be considered, and is invasive. As I said during my presentation, this can lead to potentially an embryo being damaged. So it's always a balance between pros and cons, and the consultant should be able to advise the couple on their individual case as to whether the pros outweigh the cons. So next question, how is autoimmunity issues treated? Well, that's a very good question. We normally have several medications to treat that, depending on what the problem is. But just to mention two of them or three of them, one is intralipids, which is basically a mixture of proteins and lipids, which is helpful in modulating those components of the immune system which are previously identified to be high with some test. And alongside that, in those cases where we have identified potentially an autoimmunity issue, we give also a low dose of steroids and some blood thinners, because some of these patients has also some thrombophilia issues. The two things often go together. So we include also some blood thinners in the treatment for this patient. Next question is, what would you suggest would help improve likelihood of success for a 40-plus-year-old with 2 failed IVF cycles and low ovarian reserve and egg quality issue? Well, if we think that the issue is more egg quality, then we should aim at doing anything possible to improve that quality. And that's, again, where the nutritional approach, the holistic approach can help, because through a proper preparation with the right diet, the right supplements, we can aim to improve the egg quality. And also there are some medications we can use to that extent, although the research into that is more controversial and not universally approved. But there is certainly something we can do, and we do on a daily basis to try to improve the egg quality. So if we believe the issue is the egg quality, then the attention should be focused on how to improve the egg quality. Does OHSS affect the quality of eggs, and would you have to freeze them for FET rather than having a fresh embryo transfer? So that is a very, very important topic. Yes, I do believe that OHSS can affect the quality of the eggs, particularly when this is not properly managed from the clinical side. And that's why it is important to prevent this in the first place, if possible, by designing the protocol in a very, very personalized manner, which is one of the things we do at our clinic. Nevertheless, sometimes the patient responds too much, and that's inevitable. But in that case, it is important to manage the hyperstimulation, which can be managed actually. And if it's properly managed, 99% of the times doesn't require hospitalization. It can be managed at home. So I would say if it's managed properly, it shouldn't affect the egg quality. But unfortunately, that doesn't happen all the times. And in case this doesn't happen, it can affect potentially the outcome. But to answer the second part of the question, whether we have to freeze, yeah, the answer is yes. Whenever we identify a condition of hyperstimulation, we have to prioritize safety. So freezing all the embryos is the recommended approach, because if we proceed with an embryo transfer under the risk of a hyperstimulation, it's very likely that the patient will end up being hospitalized for days or weeks, which we want to avoid at any cost. So our personal approach is to freeze all the embryos whenever we identify this condition. Going along with questions, my friend successfully had a baby with Zita West this year, age 45. Well, you know, I'm happy to see that. This is not very frequent because yeah, it's not easy, but yeah, I probably remember this patient. How are you different to other clinics like the Lister? Well, you know, all I can say on this, and it's never nice to you know to talk about other clinics, but all I can say is that what differs us from other clinics is that we try to personalize the treatment as much as possible to feel the couple treated as persons rather than numbers, which unfortunately can happen from experience in other cases, and that's very important. So it's important that the couple feels treated as persons, have a personalized treatment, the right level of care, the right time with the doctors and the staff. That is our aim, and that is what we try to deliver to every patient. I hope this has answered the question. How would you weigh up the benefits versus the risk of PGTA? As you mentioned, PGTA can damage the embryo. When would you suggest it? Well, you know, again, the risk of damaging the embryo, by the way, is not that high. It is estimated to be, I mean, from zero virtually to maximum 10%, although it's difficult to put a precise number on that, also because the damage is not always visible, is rarely visible, so you don't know. Even in case of failure, you don't know whether the failure has happened because there was a damage or because there were other aspects of the embryo which you cannot test with the PGTA, because the PGTA doesn't test for everything. It just tests for the number of chromosomes. If we have the right number of chromosomes in the embryo, it can't test for all the possible genetic diseases in the world. So when how we can weigh up the benefits? Well, again, each situation is personal. We have to look at the history of the couple, how many treatments the couple had, how many miscarriages. If a couple comes to me with 4 or 5 previous miscarriages of unknown origin, then clearly we will do whatever it takes to try to reduce the terrible experience for that couple to have to go through another miscarriage. So in that case, screening the embryos genetically after 3 or more miscarriages can shift the balance towards doing the PGTA. Also, the number of embryos is important, because if a couple has just 1 embryo available, then we might decide to just put that embryo back, because probably risking to damage the only embryo the couple has outweighs the benefits of testing this embryo. So these are the things that we have to consider on an individual basis. what nutrition do you recommend for improving egg quality? Do you recommend DHEA, CoQ10, melatonin? Well, these are all things we use, but again, whether to use all of them or just some of them depends on the individual situation, because the nutritional habits of a couple are different. So some patients do have already a very, very good situation when they come to us. So less intervention is needed, whereas some other couple need more work. So and that's why we leave this to professionals, to professional nutritionists. I'm not in charge of that part. I can deal with the medical part, and the DHEA to some extent is part of the medical expertise, whereas other things we leave this to the nutritionists, because it is their field of expertise, and we are happy and lucky to have a professional nutritionist addressing that. Then we have got, does having PCOS affect the chance of IVF success? Well, I mean, PCOS is one of my areas of interest. It always have been since I started my career. I remember I was still a medical student when I had interest in polycystic ovary. So it's something that is very, very close to me. I would be tempted to say no if it is managed properly. And like hyperstimulation, we can manage PCOS properly. PCOS is rarely the only cause of infertility, and when it is, it can be successfully treated even without requiring IVF if it is the only problem. If there are other problems, it might need still IVF to be treated, but it's not something that is particularly difficult to treat if you have the right expertise to treat it. So my answer to this question has to be no. In general, it shouldn't affect the chances of IVF success, but like everything, it has to be managed properly. Yeah, I don't see. Yeah, I can see another question just coming along. If you recommend DHEA, do you require a blood test beforehand? Yes, that is something that I do, because we try to be as evidence-based as possible, though in some cases the evidence is difficult to be gathered, but for the DHEA, that is easy. So we normally do some tests to identify those patients who might benefit from DHEA, as we do for the immune treatment. We don't do the immune treatment empirically. We try to do the level 1 and level 2 test, whatever we think is appropriate. And then after having the results, we eventually decide whether it might be indicated. So yes, so and that happens also for DHEA. Is even less expensive for DHEA because it's only 2-3 tests that we need. Normally testosterone and DHEAS. So yes, we do the test before recommending DHEA. Good. So I can see that probably we have finished the questions. So I hope you enjoyed the event and that you found this helpful. And if you would like to book a consultation with either myself or Dr. George, you are more than happy to contact the clinic directly and get in touch. Thank you very much, and wish you all a nice evening.